I'm delighted and excited to be here and honored. I want to thank John for the kind invitation and the planning committee to include me. I'm having a great time learning all new things here. This is my mission, and it doesn't come across too well, but it's about isolated voltage criteria for LVH and RVH. My sons are in the military, and so I'm a mission-oriented family. And so I'll start with the definition for LVH and RVH by voltage. LVH is the sum of the S wave in V1 and the V wave in V5 or 6 greater than 3.5 millivolts. If you're like me, you think of boxes, and that's 35 little boxes. For RVH, it's the sum of the R in V1 and the S wave in V5 or V6 greater than 1.1 millivolts. And this is really the Sokolow-Lyon criteria for voltage criteria for LVH. This is an electrocardiogram. We see so many of these at the screening. You can see with the arrow there in V5, the beginning of the R wave and the top of the R wave, and that's 32 millimeters or 3.2 millivolts. This is isolated voltage criteria for LVH. And you'll notice that there are no ST wave changes, no axis deviation, no P wave changes, pure isolated LVH. This is a finding in RVH, and you can see the beginning of the R wave in V1 and the top, and this is 17 millimeters greater than 1.1 or 11 millimeters with the Sokolow-Lyon criteria. So here's my statement. ECG findings of isolated RVH or LVH by voltage is to be ignored and disregarded in the athlete population. Now, you may or may not believe me, and you probably shouldn't, because in God we trust and all others provide data. And so I'll start first of why you wouldn't believe me. Well, LVH on ECG has been ingrained in us since medical school. We're taught that it's increased voltage is LVH. And like any other habit, it's really hard to break, and we take it for granted. But does increased voltage really represent increased mass? Does it really represent the pathologic condition of the ventricle? Or does it represent some bioelectrical factors or biochemical factors in the myocardium, or perhaps something else, but not what we're looking for in these young athletes? So why should you heed me? I mean, why is this a big issue? Because inclusion of LVH by voltage in early studies of ECG screening led to very high false positive rates. And this undermined, in my mind, the value of ECG testing of athletes. And this unfounded concern regarding high false positive rates has been repeated so often that it's become dogma amongst opponents of ECG screening, and undermines what we try to do when we do ECG screening. Little brief history is always helpful. It was in 1903 that Eindhoven, or thereabouts, described the 12-lead ECG. It's interesting that this technology is 110 years old and we're still figuring out how to use it. In 1914, Lewis reported the first description of ECG by LVH, and it was in 1949 that Sokolow-Lyon criteria came out for LVH. And this was based on the size of the heart on the chest x-ray in hypertension patients. So not really a robust database, and it's still the most popular criteria. In '68, Romhilt and Estes criteria were published, and this was based on autopsy findings of ventricular hypertrophy. And then the Cornell criteria in 1985 were based on echo showing LVH. 2009, the AHA, ACC, and Heart Rhythm Society came out with recommendations for ECG interpretation. They had greater than 30 different indices for LVH. That tells you something about it. There's not one that works very well. Now, we need to realize that ECG by voltage, LVH by voltage, developed in an earlier era and in a different patient population, mostly hypertension patients and valvular disease, and not in the population that we're looking for, and that's why it's probably not reliable. It's an unreliable finding, actually, in the adult population with hypertension. This is a meta-analysis of 21 studies in hypertension patients, and you can see the sensitivity is dismal, but the specificity is pretty good. It's actually a poor measure in children as well. This is a compilation of different criteria looking at childhood population, and you can see there that little white box, that's the Sokolow-Lyon criteria for LVH, and that's the true positive rate. You can see how poor it is, and the same is true for all the other criteria. True positive rate is really pretty poor. It ain't much better in athletes. It's present in 45% of teenage elite athletes and 23% of controls. Dr. Sharma presented that data in 1999, talked about it earlier this morning. Policia in 2000 reported it in 24% of 1,000 athletes. Samaro in 2001, 50% of teenage soccer players had LVH by voltage. And Dr. Papadakis from Dr. Sharma's group reported that 45% of adolescent athletes and 22% of sedentary controls had LVH by voltage. And then more recently, Sohaib in 2009, 30% of male recruits. And this goes on and on. So it's so highly prevalent, it's not a sign of pathology. So what about athletic training? You've heard that athletic training leads to increase in LV mass and LV cavity dilatation, but does it correlate with increased voltage? And I know the data's out there, but I couldn't find where they actually correlated LVH by voltage and chamber sizes and ventricular wall thickness on echo. I found one article from 1990, and actually they showed that there was very poor correlation. What we do know is that it does not correlate with pathology. And Dr. Sathanamam from our group in 2009 looked at Young Hearts for Life screening, looked at a little over 8,000 EKGs, found 100 with LVH by voltage, and none of them had any pathology by screening echo. So it seems that there are other factors that are of greater impact on ECG voltage than training-related changes or pathology. And what about the flip side? This has been mentioned earlier. Is HCM associated with isolated increased voltage? Dr. Clory reported and has a great summary and literature review in this Journal of Electrocardiography in 2015. Talked about 247 HCM patients and 133 Caucasian athletes with increased LV mass. They had a similar demographic, and only 2% with HCM had isolated increased voltage. Pathological LVH, however, is different. It's usually associated with other ECG abnormalities: T-wave inversion, ST depression, pathologic Q waves, left atrial abnormality. And here's some examples. You can see the deep T-wave inversions laterally along with the increased voltage, and T-wave inversions inferiorly. This is someone who has HCM. Picked this up at a screening. This is another ECG. You could see the increased voltage, a T-wave inversion, but there's also a left atrial abnormality and axis deviation. What about RVH? Well, it's the same situation. It's very common in the athletes. Up to 13% of them will have RVH by voltage on ECG, and it correlates poorly with increased RV wall thickness on echo. RVH by voltage also does not correlate with the conditions that we're concerned with finding, basically ARVC and pulmonary hypertension. So what's the evidence for this? Well, Dr. Zaidi in 2013 reported on 627 athletes, 241 sedentary controls, 68 patients with ARVC, and 30 patients with pulmonary hypertension. All of them had a clinical evaluation and an echocardiogram. And of the athletes, up to 12% of them had ECG voltage criteria for RVH. 6% of the sedentary controls had it, but none of the patients with ARVC had isolated RV voltage criteria for RVH, and neither did any of the 30 patients with HCM. And none of the athletes that had ECG RVH had any pathology. So what's the problem? Well, we assume that increased voltage is equivalent with increased LV mass or RV mass. But voltage is really influenced by many factors: age, gender, pulmonary disease, body habitus, chest configuration. This is an example of a patient I see in my adult hypertension office. This is a type of patient that Dr. Dresner and Harmon see. This is what I see at the screenings, these young athletes. They have thin chest walls or chest wall deformities, and you can see the distance between the electrodes and the heart is pretty short, and probably influences the voltage on the ECG. It's also dependent on the location of the heart within the thorax. Now, we use surface landmarks to place the ECG leads and assume that the heart is in its location relative to the surface landmarks in a consistent way, and it's not. And if you just look at chest x-rays, look at where the ribs are and look at where these hearts are located in these different chest configurations. This was looked at further in this study of cardiac MR in patients and looking at their heart position. And if you put a little X where lead V3 would be, you can see that the apex of the heart varies from A to the case C, where it's right over V3. You could imagine that the voltage is going to be greater in lead V3 in the third case, case C. Same thing is true if you look at the transverse plane, where the ECG leads would be, and the heart could be lower or much lower, and that would influence the amount of voltage that you see on ECG. Now, there are also bioelectrical changes in the myocardium. And what do I mean by this? Well, there are a number of studies that demonstrate a great deal of variability day to day, and sometimes within the same day in patients who have LVH by voltage. And the question would be why? And it's because the thinking is that electrical remodeling of the myocardium is the main determinant of LVH by voltage on the ECG, and not just LV mass. So strain from a blood pressure elevation that goes down after a couple days may change the amount of voltage. Certainly there are issues with lead placement, but even when that is corrected, there's some variability. So, 3 questions. Isolated increased voltage on ECG is frequently found in HCM. Answer is false. It's present in less than 2% of the patients with HCM. Question 2, isolated RVH on the ECG is common in these conditions. And the answer is athletes. It's not seen in pulmonary hypertension, ARVC, and who knows about situs inversus. Question 3, ECG finding of isolated increased voltage is influenced by increased LV mass. And the answer is false. Hopefully I've been able to convince you of that. So increased voltage is not equivalent to LVH or RVH and should be not be considered abnormal. Thanks for your attention.